Welcome to the deep dive. Anyone working in a UK emergency department, doctor, nurse, senior clinician, the advanced clinical practitioner role, the ACP, is just vital now, isn't it?
Oh, absolutely.
Yeah.
They're fundamental to how we deliver care.
Hmm.
You can say the backbone of the multi-professional team.
Yeah, exactly. But, and this is the crunch, isn't it? That growth has highlighted a problem.
A big one. For a long time, advanced clinical practitioner wasn't a protected title.
Which means variability.
Huge variability
Yeah.
in standards, competence, scope of practice. It really depended on the trust.
Right, and that's a real headache for clinical governance, for anyone managing the ED floor. So the Royal College of Emergency Medicine, RCEM, they've stepped in.
They have. With this, the EM-ACP curriculum, adult second edition, it kicks in April 2025.
Okay, and this is meant to be the standard setter.
That's the idea.
Yeah.
It's the definitive framework.
Huh.
So our mission today really is to kind of cut through to the official language and see what it means for you working in the ED.
So it defines the standard needed for what? Credentialing?
Exactly. Credentialing. It's the college saying this person meets a nationally recognized specialty-specific standard. No more guesswork.
Okay, let's start with the commitment, because it sounds significant.
It is. We're talking a minimum of 3 years, full-time equivalent training. 3 years.
Wow, 3 years minimum. So after that time, what's the expectation? What should this newly credentialed EM-ACP be able to do?
The aim is for them to be a highly autonomous practitioner in the adult ED, managing a really wide range of undifferentiated patients.
24/7.
24/7, 365 days a year. And crucially, this includes the resus room, handling sick and injured patients, the really high acuity stuff.
Okay, autonomous practice, including resus. That's a big statement. How does the curriculum actually structure that competence? You mentioned SLOs earlier.
Yes, specialty learning outcomes. It's the same language used for medical trainees, which helps integration.
Makes sense. How many are there?
11 SLOs in total. 7 are clinical directly patient-facing. Things like assessment, spotting the sick patient, managing resus, handling complex injuries.
So the hands-on stuff.
Precisely.
All right.
And then there are 4 supporting SLOs.
Okay, and these cover.
Things like supervision, education, getting involved in research, quality improvement, leadership, management.
Ah, so these align with that well-known 4 pillars framework for advanced practice.
You got it. SLOs 9 through 12 map directly onto those pillars: leadership, education, research, and practice development.
Right, so it's embedding that broader advanced practice role within the EM context.
Exactly. And actually, this is where they often expect a higher level of autonomy, building on their previous experience and master's level study.
Interesting. So clinical practice has one standard, but leadership might build more on their background. Okay, let's talk clinical scope. The syllabus sounds vast.
It is. For anyone supervising, the clinical syllabus covers a huge range: major trauma, cardiology, elderly care, mental health emergencies, even oncological emergencies. It's comprehensive.
And they've tried to quantify the exposure needed, haven't they? There's a number.
Yes, there is. Over that minimum 3-year training period, the trainee ACP, the TACP, needs to log direct contact with at least 2,100 adult patients.
2,100, that's a lot of patients.
It's a significant volume. It's meant to ensure breadth of experience.
But it's not just about the numbers, is it? Acuity matters hugely in EM.
Critically important.
Yeah.
And the college specifies this. That logbook needs to show a case mix where 20% of those contacts are high acuity cases.
20%, so 1 in 5 patients needs to be critically ill or injured, resus level.
Essentially, yes. Patients needing immediate life-saving intervention, high NOWS2 scores,
Yeah.
Manchester triage category 1 or 2, that sort of level.
Okay, 20%. That must be quite a challenge to achieve consistently, especially balancing service needs with training needs in a busy department.
It is a challenge, but the college views it as essential. If the credential means autonomy and recess, the training has to reflect that exposure safely and assessed.
So it guarantees they're prepared for those high-stakes situations, even if arranging that exposure is tricky logistically.
That's the rationale. Quality assurance for that high-level practice.
Right. Something for educational supervisors to really factor into rotations. Okay, let's move on to how competence is actually judged. You mentioned entrustment.
Yes, entrustment levels. It's standard language now in medical training. It's about the supervisor making a judgment, based on observation, about how much independence a trainee can safely handle.
And using the same language helps everyone understand where the TACP sits.
Exactly. It creates a common standard, a shared language for supervision on the shop floor.
So for a newly credentialed EM-ACP, someone who's just finished the 3 years and passed everything, What level of entrustment are we talking about?
They need to hit two main levels. For most of their clinical work, that's SLOs 1 to 4, 7, 8, and also 12, which is about professional identity. They must reach level 2B.
Level 2B. Okay, unpack that for us. What does 2B mean for the rest of the ED team on a shift?
Level 2B means the supervisor is within the hospital, available for queries, can provide prompt direction or help if needed, and crucially, the ACP knows reliably when they need to ask for that help.
So they can make independent decisions, manage complex patients alone.
Yes, they're autonomous.
But the senior support, the supervisor, is physically in the building.
Correct. That's the safety net. They're not expected to function with remote supervision for those core clinical tasks at the point of credentialing.
Okay, that's a clear boundary, a high level of function, but with in-house backup. You said there was another level.
Yes, for the supporting SLOs, numbers 9, 10, and 11, that's the leadership, education, research stuff, they're expected to reach level 3.
And level 3 is?
Level 3 allows for remote supervision. The supervisor is on call from home, can give advice over the phone, and would only need to come in if direct supervision was absolutely required.
So for the less immediately time-critical, non-clinical domains, they can function with greater distance supervision, reflecting maybe their postgraduate qualifications.
Precisely. It acknowledges their likely prior experience and master's level work in those areas.
This all hinges on the supervisor. Who exactly counts as the supervisor in this entrustment context? Is it just the consultant?
That's a really important clarification. For entrustment decisions, supervisor means a senior decision maker. Typically, that's an experienced doctor at ST4 level or above, or an equivalent senior clinician may be a very experienced ACP who meets supervisor criteria.
So ST4 or equivalent, that firmly places the ACP within the existing senior clinical structure.
Yes, it's not a separate hierarchy, it's integrated.
Okay, so we have the scope, 2,100 patients, 20% high acuity. We have the standard level 2B clinical autonomy. How do we know they've met that standard? That brings us to assessment.
Right, and it's different from medical training's reliance on big summative exams. The ACP credential relies on a program of workplace-based assessments, or WBAs, providing triangulated evidence.
Triangulated evidence, so multiple points of data.
Exactly. And it's prescriptive. The college mandates a minimum number of consultant supervisor assessments. This isn't optional, it's required evidence.
Okay, the big number. How many consultant assessments are we talking? I feel like consultants listening might want to brace themselves.
The total is 48. 48 mandatory consultant assessments needed for credentialing.
48. Right, that's a significant workload for consultants and the department, not just the trainee.
It's a huge commitment. It reflects the level of practice being signed off.
Okay, break down those 48 for us. What types of assessments?
You need 20 mini-clinical examinations, or CBDs, case-based discussions. And these aren't just random. They have to cover 23 specific key capabilities listed in the curriculum.
So they're targeted. What about practical skills?
Yep. 10 core skills, DOPS. Direct observation of procedural skills, things everyone needs. And then 11 additional skills, DOPS or CBDs, for maybe more advanced or specific procedures relevant to their scope.
Ensures they can do stuff, not just talk about it.
Exactly. Observed competence.
Are there assessments looking at broader skills, like managing a chaotic resus or dealing with multiple patients?
Yes. The portfolio needs 3 ESLEs, extended supervised learning events. These often look at non-technical skills, decision-making in complex evolving situations over a longer time frame.
Okay.
And also 3 ASATs, acute care assessment tools. That's where a supervisor observes the TACP, managing several patients over, say, an hour or two, assessing their flow, prioritization, clinical reasoning across cases.
Right, more holistic. And what about feedback from the wider team?
Essential. 3 multi-source feedbacks, or MSFs. And each MSF needs at least 12 responses.
12 responses each time.
Minimum. And crucially, to ensure senior input, at least 2 of those responses for each NSF must come from consultant faculty members.
Okay, so broad feedback, but with guaranteed senior clinical perspective. Now, given the emphasis on that 20% high acuity caseload, is there specific focus on resus assessments?
Absolutely hyper-specific. For the resus domain, the curriculum mandates an assessment for each of the 8 clinical presentations listed.
Each one, so things like
Major trauma, cardiorespiratory arrest, shock, sepsis, unconscious patient, severe asthma anaphylaxis, seizures, and environmental emergencies like hypothermia. You need documented, assessed evidence for every single one.
wow. Okay, no, just getting a single good at resus sign-off, you need proof across the board.
Precisely. Breadth and depth in that critical area.
And one final detail on these assessments. Timing matter.
Hugely important. The currency requirement. All 48 of those mandatory consultant assessments must have been completed within 3 years of the date the TACP submits their portfolio for credentialing.
3 years, so you can't collect them slowly over 5 or 6 years?
No. It ensures the evidence reflects recent active practice and maintains a contemporary standard. It demands continuous engagement.
That 3-year window really emphasizes the intensity, which brings us to supervision and the department's role. Who actually oversees this whole demanding process for the TACP?
That falls to the ACP educational supervisor, the ACP-ES.
And can anyone be an ES?
No, the criteria are quite specific now. They must be a fellow of RCEM or an associate specialist or senior specialty doctor in a substantive post. And this is key. They must have completed the official RCEM-ACP supervisor training based on the 2022 curriculum.
That training is mandatory now.
Mandatory. No grandfathering rights there. They need the specific training.
Okay. And supervising this, managing the portfolio, doing the reports, it's a lot of work. Does the college recommend specific time allocation for the ES?
They do. The recommendation is that the ACP-ES should be allocated at least 0.25 educational PAs, that's 1 hour per week, for each trainee ACP they supervise.
1 hour per trainee per week. That needs serious thought and job planning.
It absolutely does. If departments want to ensure high-quality supervision and prevent supervisor burnout, it's a resource implication.
And just to clarify, who can actually sign off those 48 mandatory WBAs? Is it only the named ES?
No, the assessments themselves can be completed by any substantive medical consultant in the relevant specialty, or an associate specialist or senior specialty doctor who meets those ES eligibility criteria we just mentioned.
So the assessment workforce is broader, but the overall supervision responsibility rests with the trained ES.
Correct. It maintains senior clinical input across all the assessments.
Talking about the ES's responsibility, the final sign-off sounds pretty comprehensive. They have to confirm the entire syllabus is covered.
Yes. The ACP educational supervisor formally attests that the TACP has covered the whole clinical syllabus, and that attestation has to be backed by the evidence in the portfolio, the WBAs, the logs, reflections, teaching attendance, everything we've discussed.
So the ES is the final quality gatekeeper for the breadth of experience.
They are. They're signing off on the completeness of the training journey.
And timing again, when do these final reports, the ES report and the faculty statement, need doing?
They need to be completed within 3 months of the TACP submitting their application. And this implies the TACP must be actively practicing in the department right up until submission.
So the final sign-off reflects their current capability, not something from months ago.
Exactly. It ensures immediate relevant competence.
Okay, so let's try and pull this all together. What does this April 2025 curriculum really mean for the ED workforce structure?
Well, it formalizes a really rigorous standardized pathway. It defines the EM-ACP as an autonomous practitioner operating clinically at entrustment level 2B, capable of complex care, but with that in-hospital supervisor safety net.
And level 3 for the supporting roles like leadership and education.
Right, and all of this is underpinned by that minimum 3 years training, the 2,100 patient contacts, the 20% acuity rate, and crucially, those 48 recent consultant-signed assessments.
The goal from RCM seems clear. Improve safety, improve quality, create a transparent career path for ACPs.
And ultimately, strengthen the entire multi-professional team by having clarity on roles and competence.
When you look at the details, the generic professional capabilities, the entrustment levels, mirroring medical training, defining the supervisor as ST4 equivalent, it feels like a very conscious effort to align standards, doesn't it?
Absolutely deliberate. It's creating a unified language and arguably a unified standard of senior clinical practice assessment within the emergency department, regardless of professional background.
That standardization is probably the biggest takeaway. It sets a blueprint. Which leads to a final thought, maybe for you listening to mull over.
How will this clearly defined, rigorously assessed standard for EM-ACP competence operating autonomously at level DB change the team dynamics, the clinical hierarchy, how decisions get made on your next ED shift? How does it reshape the function of the senior team on the floor?